What do you know about your child's heart health? What about their symptoms they might be having? How do they even describe their symptoms? Today, I sit down with Dr. Kevin Shannon of UCLA. Dr. Shannon has been recognized as one of the super doctors of Southern California in 2024 and one of the top doctors by Los Angeles Magazine in 2021. I hope you enjoy my conversation with Dr. Kevin Shannon. What do parents need to know about their children's heart health?
Well, hopefully they don't really need to know anything. The vast majority of children are perfectly healthy and have no heart problems whatsoever. The risk that their child has a heart condition is very low. And so unless they have a reason to suspect that, they shouldn't worry too much. Now, that brings us to why would you suspect your child has a heart problem? And, most heart problems are benign in children or not life-threatening. But the symptoms that they sometimes have, or the common ones, are episodes of racing heartbeat, which can represent a abnormal heart rhythm that children sometimes get that we can address. More concerning would be any unusual symptoms with exertion. In particular, if they have racing heartbeats with exertion, if they get lightheaded, dizzy, or faint while they're running or doing activity, that would be very concerning. Nausea repeatedly with exercise can be very concerning. Also, if there's a family history of a significant heart problem, that often needs to be screened for. And so those would be the main reasons. If you are seeing a pediatrician on a regular basis and they're doing an exam and listening for murmurs and things like that, and questioning you about symptoms and family history, then you shouldn't really have to worry about your child's heart. That's kind of our job to do that.
What is an electrophysiologist?
An electrophysiologist is a heart specialist who sub-specializes in abnormal heart rhythms. And they can even further sort of parse down what they do there are some people who only deal with device implants and heart rhythm management devices. We call them CRMs, or cardiac rhythm management devices. Others who just deal with medical therapy for abnormal heart rhythms. And then there are specialists who do something we call ablations, invasive procedures to try to eliminate abnormal heart rhythms. In pediatrics, there aren't enough of all those things for people to just do one of those things. So in pediatrics, electrophysiologists deal with all the potential heart rhythm problems that children can have.
If a child needs an EP study, what does that mean? What should the parent or the patient expect?
An EP study, EP stands for electrophysiology. What that means is we're doing a study of the heart's electrical system. And there are two goals of those studies. One is to see if we can induce any abnormal heart rhythms that we can then make it go away with an ablation procedure. And the other is to see if they have any abnormal heart rhythms that we could trigger that might be life-threatening. And depending on why you're having it, we would do one of those studies or the other. We rarely do both together. It's generally done with sedation that I call lights out, lights on. Usually the children will be breathing on their own throughout the procedure, but they won't remember anything or be aware of pain or anything like that.
When would you need an EP study?
So the most common reason for getting an EP study is something called supraventricular tachycardia. That's an abnormal heart rhythm. It's the most common abnormal heart rhythm children get. And up to 5% of children will have an episode of this before they graduate from high school. Of those, only about 1 in 5 actually seeks therapy for it, but those are the ones where they have recurrent episodes that interferes with their ability to sort of lead a normal life. And then we would say, okay, we're going to do an EP study, find out what kind of heart rhythm problem you're having, and then make it go away at the same time with something called an ablation procedure. Other time that they might have it is if they have a unusual fainting episode. So they are exercising and they faint in the middle of running down the court or down the field, and we can't find a reason for it. Then sometimes we'll do an electrophysiology study to see if we can trigger any potentially dangerous arrhythmias just to make sure it's safe for them to continue to participate in sports, or sometimes we'll find a cause for it and be able to make it go away or treat it with another therapy.
Do you have any advice for patients or parents going into an ablation, things that they need to be aware of?
I often equate the risk of an ablation procedure with the risk of driving a car in Los Angeles. If you drive a car in Los Angeles, people don't realize this, but you have a risk that's roughly 1 in 5,000 per year of dying in a car accident, which sounds, like not a trivial risk. Now, think about it. You get in a car with someone else driving all the time, and you know that person, and you know they're a good driver, and you're okay with that. And you know what driving is like. And so you don't think about the risk of climbing in a car with somebody. You do it all the time. You send your children with people all the time. You have to think of an electrophysiology study as, I'm going to trust this doctor to drive me because I know he's a good driver. And if you're not sure he's a good driver, then probably you should get a second opinion. But I think, the hardest thing about an electrophysiology procedure, or any kind of procedure, is the fact that you're giving up autonomy. You're going to let somebody else, take away your ability to have a say in what's going to happen, because you're going to get anesthesia and they're going to do these things to you. But the best way to think of it is, I'm going to go for a drive. And the risk of this is no higher than going for a drive.
During an ablation, I don't know that you actually addressed this yet. What do they do? I know they burn or cauterize little sections of your heart.
With an ablation, first thing we do is do the electrophysiology study and find out what is going on. Typically, there's abnormal tissue in your heart that's causing your heart to have rapid heartbeats. Sometimes it's just a little area of the heart that's beating on its own too fast, randomly. Other times it's abnormal electrical connections, either from one area of the heart to another or from the upper chambers to lower chambers. So first thing we do is diagnose what the rhythm problem is. Then we localize it. Where is this abnormal tissue? And then we place a catheter, which is a long plastic coated wire with a metal tip on it that has a mechanism that lets us change the shape of it so we can move it around this heart very precisely. We can put it against the wall of the heart, and then we can heat the tip of that metal tip just enough to make it like a small singe inside your heart. The temperatures that we use are roughly half the boiling point of water. So it's not really hot. It would be hot enough that if you were to touch your skin with it, you'd pull it away right away. But if you pulled it away right away, it wouldn't burn you. In order to leave a permanent lesion, we typically have to apply the heat for at least, 15, 20 seconds. And our standard is to apply it for 60 seconds.
And is a robot doing this, or are you actually in there doing this?
So there are robots that will help us manipulate the catheter, but most of the time it's easier and faster just to do it, by hand, if you will. And we use a computer system using something similar to GPS. So, we can see where the catheter is in three-dimensional space inside your body, and we can use it to move around inside your heart and create a shell that it represents the inside of your heart. And then we'll see that shell that's inside of your heart and where the catheter is in your heart. And that lets us be very precise about where we're putting the catheter. We tag each spot that the catheter goes to with what the electrical signal is there. So we know where the abnormal signals are, where the abnormal tissue is. And then we can be very certain when we ablate or burn that we're in the right spot.
And then what about parents whose children, maybe they can't get an ablation or they're not a good candidate for ablation, so they get a device implanted? Any tips for those parents or patients?
I have a couple tips. One is always involve your child in the decision. And it's a very different thing than, say, appendicitis, where you're really sick and people say, we're going to do surgery, and you wind up with a scar, but there's nothing left inside you. When you get a device implanted, you don't want your child to wake up not knowing this was going to happen and have something inside of them that they didn't really feel comfortable with before it was implanted. Because once it's there, it's really hard to sort of get comfortable with the concept. And some people feel like, okay, I need to protect my child, and we're just going to do this and not tell them what's going to happen, or tell them when they come in. But I think it's really important that the child be comfortable with what's going on at a sort of age and developmental appropriate level, and that they understand that this is being done for their benefit. So involve the child in the decision, and then make sure they understand why they're getting it and what it's going to be like and what it will look like afterwards. And then make sure that the person who's doing it is experienced in doing this in children, and that the institution is experienced in doing this in children, because children aren't just small adults. They have different physiology. They are going to grow. And so it's important to take into account all the things that make children unique, even, or in particular, their psychological well-being. And, you don't want them to be put into an adult recovery room where people are being resuscitated next to them, because they don't know the difference between them and that other person. And they think, oh, that's what's going to happen to me. So you need to make sure it's a pediatric environment.
What advice do you have for a parent whose child does need a device implanted and they're not sure where exactly to go, or they don't feel comfortable with where they're at? Are there any resources that you might suggest to them?
There are lots of resources. Some of them are online. There's something called PACES, which is the Online Association of Pediatric Electrophysiologists, and they have a list of pediatric arrhythmia specialists by location. also organizations like the SADS organization, just Sudden Arrhythmia Death Syndromes Foundation, and they have support groups and resources that they, can provide, locally, for people you can talk to depending on exactly what's wrong with your child. Often asking the social worker at the institution that you're dealing with, are there other people who've been through this who can talk to my child? That can be helpful. Sometimes finding a person who's still young but slightly older than your child who's been through it can be very helpful. And then, in terms of comfort, I tell people all the time, never hesitate to get a second opinion if you're not comfortable. And the goal of that isn't necessarily to change doctors. It's just to be comfortable with the decision before you go through. And any major intervention, you should consider that. And the major intervention is the one happening to your child. The ones happening to somebody else's child is not your problem, and not, whatever that is, no matter how major, your child is the only one you have to worry about. And even if people consider it minor, it's not to you. If you're not comfortable, get a second opinion. Be comfortable with the decision, because if you're not comfortable, your child's not going to be comfortable, and that comes through.
Is there a certain age when children develop arrhythmia?
Children can have arrhythmia at any time. We treat pregnant women with medications because the fetus is having abnormal heart rhythms. And, as you get older, you're more and more likely to have a heart rhythm abnormality. It's, I tell people all the time, anybody who lives long enough gets a heart rhythm abnormality. And so there is no age at which it's, more or less likely to develop, with the exception that for some reason between the ages of about 1 and 5, it's rare to have arrhythmia. And I think that's just the size of the heart is the wrong size to sustain arrhythmia.
Is there a common cause of arrhythmia in children?
Well, the most common cause of arrhythmia in children is something called an accessory pathway. It's an abnormal connection between the upper and lower chambers of the heart. Most of the time, the electrical signal travels from the upper chamber to the lower chamber through the normal connection and the abnormal connection, and it runs into itself, and everything's fine. But every now and then, kind of at random, it will go down the normal connection and not the extra connection, and that allows it to come back up the extra connection. And then it goes down the normal connection, up the abnormal connection, down, up, down, up, down, up, going in a circle. And your heart will go from beating normally to racing in one beat. And then that usually lasts for minutes to hours. And then either you go to an emergency room or some medical facility and they give you meds to stop it, or it will stop on its own. There are maneuvers children sometimes learn on their own, or sometimes are taught when they see a doctor with complaints about palpitations, where they can make it go away, on their own. And we call those vagal maneuvers.
Are there key words that your child might say that could indicate that they are feeling an arrhythmia?
Well, it's funny because most children who present with arrhythmia have been having it for a while. And sometimes they think it's normal because they've been having it for as long as they can remember. Sometimes they'll have mentioned to their parents, my heart's bleeping. Bleeping is the word I've heard most commonly associated with abnormal heartbeats. And the parents will feel really bad when their child finally has an episode and gets diagnosed, because they're like, oh, he's been telling me for years he's having that. First of all, no big deal, no harm, no foul. And, children tolerate these arrhythmias very well. But, when they say my heart's bleeping repeatedly, or you can see their heart going rapidly through their chest or in their neck, that will be a sign that they need an evaluation for that.
Many parents ask me if they should get their children's heart screened. What are your thoughts on that?
Screening, particularly prior to athletic participation, is a pretty hot topic and has been since I started my training in 1990. And no one knows the right answer to that yet. And part of that has to do with the fact that we can screen for diseases that give you a risk of sudden death, but we can't pick out those people who will manifest that risk or not. We can tell you that it may be higher in some people than others, but there's no disease where there's like, yeah, you're the one who's going to have that event. And so screening might tell you, okay, you have a risk, but then you have to decide, is the risk so high that I wouldn't do the sport? It's a very complex set of decisions. Now, obviously, nobody wants their child to go out and die. And when it happens, it's a tragedy. And when you're the parent, you would do anything to have prevented that and to try and prevent it from happening again, because it is so devastating. But the downside of screening is that we wind up telling a lot of children who aren't going to die that they can't play sports. And, as tragic as it is to have somebody die during a sport, a young, healthy person, it's also difficult to tell someone whose life is centered around a sport, you can no longer do that. And, based on some data in Italy where they do this routinely, they restrict 2,000 children for every one death they prevent. And if you're the parent whose child doesn't die, it's no brainer. Yeah, I don't want my child to die. If you're the 1,999 children who are told, you can't play your sport even though you're not going to die, that's a little harder. So I think in my mind, even though these are tragic and there are some cases where we can say, okay, you definitely shouldn't be playing, we also have to have a acceptable risk paradigm where we say, okay, you know what, your risk is higher than everybody else, but it's not so high that it's not worth doing this because the benefits of participating in sports are worth it. At the other end of that, we also want to have paradigms in place or programs in place that if there is a tragic event, we respond to it right away, because the vast majority of children who have sudden cardiac arrest on a playing field or on a court, it's a witnessed event. And if everybody's ready to do the right thing, that child could be resuscitated with a near 100% intact outcome. But the program has to be there ahead of time. And there need to be people there. Everybody knows about Bronny James. He was the second USC student in a year to have a cardiac arrest at basketball practice. And they were both resuscitated. Both have gone back to playing because their trainers were trained to respond right away to get their circulation back before paramedics ever arrived. They were both sitting up talking before the paramedics got there. That's the kind of programs you need to have in place really to make sports safe. AEDs are now commonplace. The price actually came down really low, and for some reason it's gone back up. But they're not so expensive that they're prohibitive, but just having it isn't enough. You have to have people there trained to recognize cardiac arrest and respond appropriately. So there have to be AED programs, not just AEDs. And if I were going to spend, it would cost millions, if not billions of dollars to screen every athlete in the United States. It would make more sense to spend that money training people to resuscitate the athletes, because not only are athletes protected that way, but so is everybody else, because all those people you've trained are out there in society. And the Boy Scouts, in order to get an Eagle Scout badge, you have to learn CPR. And according to the Boy Scouts, 1% of Eagle Scouts save a life in their lifetime. So you have this added benefit of training all these people to respond to an emergency.
Do you think that they should be trained in CPR and in AED?
Well, now I teach CPR and AED to lay people. I teach lifeguarding. I teach people in our church. And it's part of the AED use is part of CPR. And it's very straightforward. And you're protected from liability. It's obviously you don't want to be the person who tries to resuscitate somebody and fails because you just feel bad. On the other hand, you'd hate to be the person who saw somebody die and couldn't do a thing because you didn't know what to do. So, there's no upside to having somebody have a cardiac arrest in front of you, but at least if you're trained, give them every chance to survive. AED use is very simple and straightforward. It's not rocket science. You open it up, it then starts telling you what to do. You put the pads on, and there are pictures on the pads where you put them. Then you press a button and it says, okay, don't touch them. It analyzes the room and it says shock advised or no shock advised. If there's no shock advised, no matter how many times you press the shock button, it will not deliver a shock. If it says shock advised, it will charge, and then you press a button, and some of them will deliver without you pressing a button, but you then deliver the shock and they wake up. When it works, it's probably the most satisfying thing you can imagine. And so it's not hard to do. And even if you've never been trained, if you are at the airport and somebody has a cardiac arrest or collapses in front of you and you don't feel a pulse, they're not breathing, send somebody to get the AED you just walk by, because everybody's seen them in the airport. They're every few hundred yards, and it just follow the directions.
Yeah. So here's my question: do you think that parents should get AEDs for their homes instead of screening because some parents are very concerned. People are concerned. Do you screen? Do you get an AED?
I don't think you should. AED should not be a burden. And if you got an AED and it's in your home and you're driving to practice and you realize, oh wait, I forgot the AED, or it's in the other car, then you feel like, oh, I should drive back and get it. But the odds you would need that are so small every day that it's not worth the trouble of carrying it with you. They should be in places where children, might have cardiac arrests, although that's extremely rare. The risk of a cardiac arrest in someone high school and lower is about 1 in 100,000 per year. It's very small. It happens because, in LA Unified right now, there are close to 500,000 students. There's a long list of conditions that can cause sudden death. We know what they are. We can screen for most of them. If we have a suspicion, we can almost always tell you, whether or not you have it. How much screening you do is kind of related to, is there a reason to do more screening? Finding out you have one of the conditions, where you have a variant in, say, your coronary artery that 1 in 1,000 people have, but only 1 in 100,000 of those, people die suddenly. Do you need open heart surgery to fix that? We don't know the answer to that, and some people say, okay, I want to have the open heart surgery and reduce my risk. Other people are like, you know what, that open heart surgery sounds like it's way riskier than just having this. I'll take my chances. And we don't know the right answer to that question.
I coined this phrase heartquake because there's so much shame and blame. I've been living with heart disease since I was 18, nearly 30 years later. What do you think of that term, heartquake?
I don't really know what to think of that term because it obviously helps you. And it's hard for me to put into my life, does heartquake help me? But it reminds me of, and I hate to give away my age, but there was an episode of Magnum P.I. that I saw once where Tom Selleck is rowing his kayak or whatever in the ocean, and a rogue wave knocks him over and the kayak gets washed away. And now he's treading water in the middle of the ocean and he can't see land. And then this shark starts to circle him. And he tells this story about his parents once told him about the monster under the bed. If you give the monster a name, it's less scary. And that makes me think of giving the monster a name makes it less scary, whatever that name is. But if you have this thing in your life of which you have no control and it happens randomly and it makes you feel awful and no one else can really see it, it's a little bit like having the monster under the bed that's terrifying you, except it's more real than that. If you have a name for it, that makes it less threatening and makes you feel comfortable with it. And, especially if that thing sort of makes people understand what it means to you, like heartquake might, I think that would go a long ways in helping you deal with this thing, whatever it is. And I'm a big fan of, sort of not just trying to push your fears away and, let them be under the surface, but sort of looking at them and saying, okay, this is what it is. This is why I'm afraid of it. And this is what I can do about it. And try and take control of that thing, even if it's just giving it a name, because it's the randomness and the loss of control that makes abnormal heart rhythms so debilitating.
Thanks for watching Heartquake Media. Make sure you check out our website and social media for more information on heart healthy living. And remember, wellness starts with the heart.